Hello, future PTAs. I hope that you are doing well. Today we are going to go over the hip lecture. So we will start out with our hip anatomy. So here are our deep muscles of the hip, the ones that are underneath the surface and harder to find. So our psoas, we have iliacus, we have some adductor muscles. So this is adductor brevis, we have pectineus. There's also our piriformis. Back here we can find through the posterior part. Obturator externus, internus is also in there as well. Those are some of our deep muscles of the hip, more of our stabilizing muscles. You know that gluteus medius is also a stabilizing muscle, but we can kind of palpate it. It's a little more on the surface. So here are surfacey muscles that aren't quite as deep, more superficial muscles that we can palpate. So all the glutes we know. Then going down the back of the leg would be the hamstrings. Down the front, of course, is our quads, our sartorius, tensor fasciae latae, and then our core muscles and our back muscles. So we will palpate those together in class, and most of those you're very familiar with at this point. Here are referred pain patterns of the hip. Now these are referred from the hip, different ailments where they normally cause pain, rather than what we've looked at in the past, which would be the referred pain patterns from organ involvement. So true hip pain coming from the hip joint itself usually refers pain to the anterior thigh and groin region. And that could be from maybe arthritis or from like a torn labrum, impingement in the hip. All those things can cause pain in that area, anterior thigh, groin region. Then with neuralgia paresthetica, we're going to talk about that. That's from a nerve entrapment. The nerve distribution is this area, and so this is where it is felt. With SI joint pain, it is felt right here where the SI joint is on the posterior aspect, where the sacrum meets the ilium. And we typically have a little dimple there to show us exactly where we're at, especially in people who are smaller or more toned. And then any type of bursitis would be over a bursa itself. So we have trochanteric bursita over the greater trochanter, or ischio-gluteal bursitis over kind of the butt bone there. And then with sciatica, it is typically more of a diffuse pain, diffusely through the hip and down the leg. Remember, we talked about it being down the posterior part of the leg, typically all the way to the foot to be true sciatic pain. The nerve in itself is innervated by the L3 nerve root. And so if there is an entrapment of the L3 nerve root as it's exiting the spinal column, then that can cause hip pain as well. One thing I forgot to mention is the hip is in itself called the iliofemoral joint, and it is a synovial joint. It's where the head of the femur connects with the acetabulum. Forgot to mention that on the first slide. Okay, so now we're going to the angle of inclination. So that is how much of an angle is between the top of the femur and the femoral neck going towards the femoral head. So the normal angle is about 130 degrees. And if it is a wider angle, which would really make the bend less obvious. So the leg would look, the bone would look more straight. It would have less of the bend, but it'd be a wider angle, greater than 130 degrees. We call that coxa valga. And if it is less of a angle, a smaller angle, which would make a more significant, more obvious bend in the area, so a greater, more drastic turn from the head of the, from the proximal femur to going towards the head of the femur. That's called coxa vara. So coxa vara creates a greater Q angle. So it makes this angle up here wider, which would mean the hips are a little bit more wide, And when our hips are wider, we typically have a greater Q angle. And the Q angle is the angle that the femur meets the tibia. And when we have a greater Q angle, it puts more tension on the medial aspect of the knee, on the medial ligaments, like the ACL, MCL. And so it sets us up for an injury. It makes it more likely for that patient to get injured. So coxa vara increases the Q angle and makes it more likely for the patient to have a knee injury. Then we want to talk about GENU valgus initiated at the hip. Remember, GENU valgus is knock knee when the knees come in and touch each other. GENU varus is more of a bow-legged when the knees bow out. And of course, if you have coxa valgus would create a GENU varus, so a larger angle at the hip, no more than 130 degrees, will create less of a drastic curve going down, and so the bone itself comes down more of a straight, so then it sets you up to have a wider angle because your hips are typically wider than your knees, so the bones come down at a wider angle, so it makes you more likely to have GENU varus because the knees have to kind of come out to meet that bone underneath the hip, versus if you have coxa varus, then there's a greater angle. The femur comes down at a nice angle, creating a larger Q angle and making you more likely to have GENU valgus, which is your knock knee. The other thing that can do this, maybe if it's not a true deficit, they have a normal angle of inclination at the head and neck of the femur, then it could also be from muscle weakness, specifically the gluteus medius. So any weakness in the muscles that do abduction, extension, and external rotation, if those muscle groups are weak, then it causes the hips to collapse in. You've already seen when you're standing on one leg, if that gluteus medius is weak, the other pelvis will drop, and it will cause a GENU valgus at the knee because of the drop of the hip down. And so strengthening the gluteus medius is a great thing. Even if it is structural, it's just great in supporting the area, but if it is specifically from a weakness, then that's kind of the cure to keep that from setting them up for a injury in the future. And again, that's the ACL, the MCL, and even the medial patellofemoral ligament that are likely to get injured in a patient that has that greater Q angle, whether it's from their bone structure or from weakness in the pelvis stabilizer, specifically the gluteus medius. Okay, so the functional relationship. So now we're going to talk about functionally, if your pelvis is tilted one way or another, what that does to the alignment of the bones surrounding. So if it is tilted anteriorly, an anterior pelvic tilt, then the hips will be in slight flexion. So you'll have some slight flexion there at the hips, and you'll have an increased lordosis of the spine, which would be more low back extension. And then when the pelvis is tilted posteriorly, then you would actually have more of an extension occurring at the hip joint and more flexion or rounding out of the back. So rather than the lordotic curve that should go in slightly, this is the normal, it would be more of a flat back. So it would just kind of go straight up. That's with a posterior pelvic tilt. With a lateral pelvic tilt, then one side of the pelvis will be lifted higher, the other side will be tilting down, and the side that's higher, the trunk will kind of collapse in towards that side. So there will be less space between the ribs and the pelvis on that side and more space on the opposite side. That would be like with a lateral pelvic tilt. So it would create some hip adduction of the side that's higher, because it has to go in towards the middle, and abduction on the side that's lower. And of course, side bending towards the higher side. I just mentioned that. So those are, if the pelvis is out of alignment, how it will functionally affect the other anatomical structures surrounding it. We can have several nerve injuries at the hip. So with the sciatic nerve, we know that's often caused from a tight piriformis because the sciatic nerve typically travels above, below, or pierces through the piriformis. So if it's tight, it adds extra pressure. So piriformis syndrome is one of the causes of sciatica. There are others, but typically it is tight in people who have sciatic pain. The obturator nerve can get damaged during childbirth, just based on the head of the fetus pressing on that nerve as the hips spread and it descends down the vaginal canal. So that would be the obturator nerve. And the femoral nerve can be damaged. I should have been pointing, that's the obturator. The femoral is more lateral out here. It can be damaged when you fracture the femur, especially really any of the places, but it can be damaged with that. It can be damaged with relocation of a congenital dislocation. So if the child is born with the hip dislocated, which is a condition we'll talk about later on in this PowerPoint, then when they try to put it back in, it could actually pinch and impinge that nerve from that process, and it can also get pushed on during childbirth. And then neuralgia paresthetica, I mentioned that earlier, that lateral portion of the thigh is fed, innervated by that nerve, by the lateral femoral cutaneous nerve. So when that nerve becomes entrapped, then we have anterolateral thigh pain. So neuralgia paresthetica is entrapment of the lateral femoral cutaneous nerve. With hip hypomobility, you know that is just decreased movement of the hip. So we want to do treatments that can increase the movement. So joint mobilizations. We want to, of course, get them out of pain if they are doing muscle guarding or if pain is kind of the limiting factor. We want to, for sure, do some range of motion. Of course, we start with passive and then we go to active assistive and eventually to active range of motion as we progress through. And stretching of the area to loosen up any of the tight areas that are causing it to be restricted. Remember, the psoas is one of the places that's, and the hip flexors, those are two of the commonly tight areas that we have to loosen up in order to get more hip mobility. Of course, the piriformis as well. And then going towards weight-bearing activities, you can do some functional gait training, balance training. Also, during the first stages, providing an assistive device if they need a walker or something to support the and decrease the amount of weight or pressure on the hip, then that would be suggested. And then, of course, strengthening your stabilizers. Remember, we always do proximal stability before distal mobility. So just like with the upper extremity, we always focused on strengthening the shoulder. Even with a hand patient, you want to strengthen the shoulder proximally so that they have good stability there and can control the distal movements. And it's the same with the hip. So anybody with lower extremity issues, we want to do some proximal stabilization training in order to give them good stability so that as they're moving, they're not losing form. And the main muscles, of course, are my favorite, the transverse abdominis and the gluteus medius. I wanted to say multifidus because that usually goes hand in hand with transverse abdominis, but that is also one of the stabilizers of the low back and hip. But The primary two that I would say are most important are the transverse abdominis and gluteus medius, and stabilizing the hip. And we want to do those exercises with any patient. If they have knee pain, if they have poor alignment in the ankles, if they have gait abnormalities, most of those patients will require some stabilization training proximally. And even those with hypomobility, we want to make sure that we are strengthening the stabilizing muscles and stretching the mobilizing muscles so that they have as much movement as possible. Okay, so there are various hip dysfunctions. Now, macro traumas, the terms that would go into that category would be a hip dislocation, a fracture, any type of muscle strain that involves the hip, like the hamstring or the groin, would be a macro trauma. And then contusion. So this picture here is a picture of a hip pointer, is what we call it. Typically in the sports world, it happens oftentimes with football or something, maybe soccer even. If you have kind of an high impact injury or fall on that area, it creates a bruise right over the bony prominence, and that would be like a hip pointer. Those are all large traumatic incidents that can happen at the hip. But we also have micro traumas such as bursitis. So over time, repetitive trauma can cause inflammation of the bursa sac, and that is typically either in the trochanteric bursitis over the greater trochanter, or so right here over this bone, or ischiogluteal bursitis, iliopectineal can cause more anterior pain. I haven't ran into that as often as the others, but and then there are other bursas is basically what I'm mentioning here. So, but the most common would be over the greater trochanter or over the ischial tuberosities. And then you could also have tendinitis. So any of the kind of chronic inflammatory issues would be considered a microtrauma. And the tendinitis, the common tendinitis is that affect the hip, would be of the hamstring tendon, adductor longus, iliopsoas, and rectus femoris. So just depending on what area is tight and inflamed, there could be some issues with tendinitis with repetitive microtraumas. Okay, so now we're going to go into a more specific diagnosis. So with hip fractures, and this is really common, especially in our older population, especially the females, because of osteoporosis being more common among females. Specifically, when a woman stops having a menstrual cycle for every year that she does not have a menstrual cycle because of the lack of estrogen, there is a certain percentage of bone mass, a higher percentage of bone mass that is lost than over a normal year. So any woman that started menopause early, or maybe had a full hysterectomy where the ovaries were removed as well at an early age, then they have lost all their hormones. And if they did not do any hormone replacement therapy or anything, they're at a higher risk for osteoporosis. And this is also true of female athletes that start their period later in life because they do not have the body fat percentage needed to actually go through the puberty changes that allow them to start their period. So just being aware of that is one of the reasons that women often will have a fracture before. And another thing I would like to mention is oftentimes a fracture actually occurs before the fall. So a lot of people are scared of falling as they get older, and they are afraid to fall and break a hip. But in many cases, they actually break a hip, and that's what causes them to fall, especially in females who have osteoporosis, that they're walking and it's gotten so brittle that they take a wrong step or step off a curb funny, and actually the hip breaks, and that causes the fall. But either way, whether it broke because of the fall or it caused the fall, typically some type of surgical fixation is going to be done in order to repair the fracture. If that's not possible, maybe they're too frail, they're not in good enough shape to feasibly make it through a surgery, or maybe they're so up in age that they don't think they'll have enough time to really recover properly. If there's anything that the surgeon feels this is not going to be a successful surgery, then what they'll do is keep the leg in traction, in kind of a pulled apart position, a distracted position, until it begins to heal. And then they will continue to avoid weight bearing for a very long time, for usually 10 to 16 weeks. So they will kind of place the leg in traction initially as it starts to heal, just kind of to keep the bones from, fusing to each other and making the hip joint completely immobile, but to also allow for proper healing within that joint. And then they will be instructed to completely avoid weight bearing for 10 to 16 weeks, which is really, really, really difficult. Getting up to go to the bathroom and shower and all those things. So, but if the surgery is possible, then there's a few different types of surgical interventions they could do. So here, this is a pinning procedure, where they place pins into, this is if the femoral neck is broken, where they place pins into the area. This is more of a hip replacement. They've kind of removed the broken piece and drilled a brand new, fresh metal femoral head down into the bone. And then if it is in the, it's an intertrochanteric fracture rather than a fracture of the femoral neck, it typically takes more like a rod and pin, because they have to secure both ends. And you could possibly do a hip replacement there if necessary. But so different ways of fixing that, just depending on which portion is broken and the viability of the bone that's left. If they have significant osteoporosis, then drilling anything into the bone is actually going to create more broken pieces because it's so brittle. And that might be just someone who has no surgery, or maybe they have extra precautions put in place to keep the bone from shattering when they drill into it. As far as treatment goes after a hip fracture, first we start with bed mobility and transfers, proper use of assistive device, just teaching them how to move around and get the functional things done that they need to do without placing too much weight on the hip, and while maintaining hip precautions if they have them, and also while avoiding and coping with the pain that's caused by every step. So typically remember the hip precautions if there has been maybe a hip surgery from the anterior portion, the anterior approach, that those hip precautions would be, now I'm second guessing whether it's the anterior approach or the posterior approach. The old-fashioned way of doing the hip surgery, and I'll clarify this in class once I remind myself, I don't want to get confuse anybody, but the typical hip precautions are to avoid flexion past between 60 or 90 degrees, to avoid adduction past neutral, and to avoid internal rotation. So avoiding flexion past 60 or 90 degrees, adduction past neutral, and internal rotation. Those are the three that are typically most likely avoided. There are several different surgical approaches that either have the opposite hip precautions or no hip precautions at all. It's getting more and more common to have no hip precautions, but those all should be clear in the notes. So it's important, of course, to do a proper chart review before you see any patient, but to make sure you understand their precautions. So if they do have precautions, teaching them those and teaching them how to move with those. So remember, as they're transferring, straighten the leg out. Otherwise, when you lean forward to sit up, you're breaking hip precautions. As they're moving in bed, straighten that leg out so that they're not bearing weight on it if they're not supposed to, or they're not folding it in past neutral or internally rotating. So just being aware of those precautions if they are in place. And then once they are cleared by the surgeon, so typically they'll have a certain amount of time that they have weight-bearing precautions and possibly hip precautions, but once they're cleared, then you would begin some strength training, range of motion, functional mobility, and initially you can start some isometric, like glute sets, quad sets. You can start ankle pumps. Ankle pumps we typically start right away to keep the circulation going, to decrease the likelihood of getting a blood clot, a DVT. So some of those mobility type exercises you can start right after surgery. But most of the time, directly after surgery, the goal is to get them up. Most of the time, they want them to be able to get up and show that they can kind of take a few steps and make it to the bathroom and do that before they are discharged. And a lot of patients will, after a hip fracture, especially depending on their age, will be discharged to like a rehab facility or sometimes assisted living facility, depending on their needs. As far as hip precautions go, I also do want to mention that after a ORIF, remember that is open reduction internal fixation. After that type of surgery, open reduction internal fixation, so they've put in pins, they've put in rods and screws, they put in any of this hardware, there are not hip precautions. There are typically not any hip precautions needed after that. The hip precautions I was talking about is after other types of surgery. Okay, so degenerative joint disease is also called osteoarthritis, and we have learned about that with other parts of the body. It's the same types of symptoms, same cause, but it is common to get arthritis in the hips because there is a small surface that is doing a significant amount of weight bearing. So a lot of weight is absorbed at the hip, and specifically, okay, sorry about that. Had to pause the recording for a moment. Okay, so we were talking about osteoarthritis of the hip and how it is common. So typically there's also a common pattern that we see when someone has osteoarthritis of the hip. We see that internal rotation is the most limited and the first one to notice a limitation. And then they start to notice limitations in hip extension past neutral, hip abduction, and eventually in hip flexion past 90. So that could be pain they notice, it could be stiffness, it could also be eventual true limitations that they notice with that pattern: internal rotation first, then extension past neutral, then abduction, and eventually flexion. As far as treatment for a patient with degenerative joint disease or osteoarthritis of the hip, there are two different categories. So if they're in the acute, reactive, or advanced stages, then you're mainly focused on decreasing their pain and inflammation. So this is the stages where they're having basically a flare-up and in a lot of pain. So you're trying to make them as comfortable as possible, help with inflammation. You can also do some functional mobility, as far as here is now how you do this without causing more pain, or now that you're in so much pain, here's how you stand up, here's how you move from here to there. but not a focus on strengthening or really pushing the range of motion. You're mainly focusing on how to cope with the current flare-up. If they're in subacute, chronic, or a low reactive stage, then you can do range of motion exercises, strength training, endurance training, and of course functional mobility, but that would also include gait training on different surfaces, balance training. All of those types of things could be used for a patient who's not necessarily in a flare-up but has the condition. Okay, so with a femoral acetabular impingement, so there's several different types of impingement that can happen in the hip. With cam impingement, that is when the femoral head is large, and so it increases the contact with the acetabulum. So the femoral head in itself is too large. It has additional bone formation right here, or larger in size than the acetabulum, so it's in contact as you're moving with the acetabulum. So it's causing impingement with movement. With the pincer impingement, the acetabulum itself has too much overhang, so it should have an area where it cuts off to allow free movement, but in that area there's extra bone growth. So it has the cam impingement, the ball's too big, the pincer impingement, the socket's too big. And then with mixed, then both are too big. So there's just too much bone in the space, and they're pushing together and rubbing the whole time. Bone spurs can develop. That would be an abnormal bone growth that can be there from birth. You could have a bone spur that was already there from birth and it's been there the whole life and it's always impinging, or it could develop based on extra pressure in that area. Then it becomes, the bone begins to form in that area and create a bone spur. And each of these things, any impingement in that area, it's impinging the labrum, the cartilage surrounding the area, and it can cause a labral tear. So I personally tore my labrum in my hip. That's why I had my hip surgery, and I had all three. I had the cam impingement, pincer impingement, and a bone spur. So they went in, they shaved off part of the head of the femur, they shaved off part of the acetabulum, they shaved off the bone spur. I had an extra overhang even of the labrum itself, so they shaved off part of the labrum and reattached it where needed. And so if there is a torn labrum, you can do some core strengthening, the deep stabilizing strengthening. You can do some glides, like inferior glides and distraction stuff, even with movements. Maybe put a mobilizing belt around the hip and pull it downwards as they're doing hip flexion and things to try and decrease the impingement and decrease the pain in the area. Anti-inflammatory techniques, ice, ultrasound, things like that can be done to help with the pain and stuff. But the tear itself is not going to heal unless, there's some type of surgical procedure. So if they cannot live with the pain, then it is recommended usually they'll still try physical therapy first after therapy to have surgery. So another situation with that, I had my oldest son's teacher actually came to me with all these symptoms, pinching pain in the groin and pain with flexion, all the symptoms of impingement, and wondering what to do. And she said basically after about 6 months it went away, but in the meantime they had been doing a lot of MRIs and things trying to figure out what's going on. And hers, it had been impinging. She had started a workout plan, doing a lot of lunges and stuff, and it had started impinging and just kind of got inflamed, and it took several months of not working out before it went away. But what would happen is if she had just tried to push through, which is what I did. I was training for a half marathon. I felt the pain in my hip, but I thought it's just from running too much. Once I'm done with this, it'll go away. Once I finished and started resting, it never went away. So if she had pushed through that impingement probably would have eventually caused a tear. But since she stopped early enough, the inflammation went down and she has no pain now. So if you catch it early enough, I would do therapy and see if it's maybe just inflammation and not a true tear, and then hopefully it'll get better. So now we'll talk about a true labral tear. So a torn labrum typically happens from repetitive impingement. And the labrum, of course, is the cartilage ring that surrounds the inside of the acetabulum. And the symptoms can be treated without surgery, but it's not really going to fully return to baseline without surgery unless it's just inflammation of the labrum or inflammation in the area. We already talked about the treatment with core stabilization with modalities and, of course, with stretches just to decrease extra tension on the area. And I don't think anything extra needs to be said about that. All right, so hip dysplasia. This is that congenital hip dislocation that I was talking about earlier. So with hip dysplasia, the acetabulum is not, it's immature, it's not large enough yet to fully cover the femoral head. And so in a normal acetabulum, it is curved enough that as you move the femur, it stays inside the acetabulum. Here, it's partially developed, so it's not large enough to actually hold it in place. So as the baby moves, it dislocates. It's just not, it just kind of rolls off the acetabulum because the acetabulum is too small. That's called hip dysplasia. And typically, they'll be born with it because they're all crunched up in the womb, and right as they're delivered, it will already be dislocated. It could, happen later, but typically it's caught in the infantile screening. They screen for it at birth, and most of the time it's caught. There are times when it's missed, or maybe it dislocates a little bit later in life, but if it is missed, some of the signs that it's happening is if the child is avoiding weight bearing. So oftentimes you'll go to stand them up, and most babies, even when you put weight on the balls of their feet, they have a reflex that causes them to stiffen their legs out. So it'll basically be like as if they're standing up, they're pushing to stand up. But with a child with hip dysplasia, as soon as you put any weight on that foot, they'll pull that foot up. So the foot, the side that has hip dysplasia, as soon as you start to try and weight bear on that side, they'll pull that up. So if they're avoiding weight bearing on that side, they're constantly pulling that side up. If they're delayed on their motor skills as far as walking, or if they begin walking and they're walking with a limp, trying not to put weight on that side, those are all signs to certainly check for hip dysplasia. So some of the things that they can do, most of the time it's treated medically. It's not necessarily, we would do physical therapy after the medical treatment, but they typically will either do some type of a surgery to fix, or they will put them in a cast or a splint that keeps them in a certain amount of abduction and flexion to keep the hip in place as the acetabulum matures and develops. And once it's developed, then they can, remove those and it's fine. So sometimes it'll be a full cast across the pelvis that keeps them in that position, and then others it's a brace like that. And then as far as once that is taken off, you can do some mobility training, some gait training, some functional, moving, rolling, all the things, the motor skills they should be working at the age that they are at, and trying to retrain them to do those now that they're not in pain with weight bearing. Slipped capital femoral epiphysis. So remember, the epiphysis is the growth plate, and this is a disorder that happens in adolescence, and it is where the femoral head just gets basically stuck in the acetabulum, and it stays in place in the acetabulum while the rest of the femur shifts. Slipped capital femoral epiphysis. So if this is the femur and here's the head on top of it, it stays in one place and the femur shifts out from under it. It occurs, of course, in the epiphysis or the growth plate, and they really don't know the exact cause. Why it happens to some and not the other. It's kind of a anomaly at this point, but symptoms include pain, stiffness, instability of the involved hip, and oftentimes when they have it in one hip, it's likely that they will have it in the other at some point. Not a guarantee or anything, but this is an emergency situation, and it does require surgical fixation. So if all of the sudden teen or a preteen begins to have significant pain, stiffness, and instability in their hip, I would certainly recommend them going to a medical doctor as soon as possible so that they can have it surgically fixed. If it is a severe case, the affected leg will externally rotate and appear shorter than the other. So here is an ultrasound where they had it. It's not an ultrasound, x-ray, where they had it on the left. So the right is normal. It's just a normal femur and acetabulum. And then here, right there, is the kind of breaking point. So here's the head of the femur, here is the epiphysis, and here is the femoral shaft that has slipped from underneath. And there's the area. And see how it's up higher than the other? And so the way it slips kind of in a posterior direction would make it look like that leg is shorter, the affected leg. And then as far as PT goes, we refer out if it's an active, and then once they've had the surgery, they'll probably need range of motion, strengthening, mobility training, things like that to get them back to where they were. All right, so general treatment techniques, okay, for most hip patients. So pain management, modalities, especially to decrease inflammation, manual therapy and stretching of any tight areas, loosening up the psoas, the hip flexors, could be the hamstrings, adductors, those are kind of commonly tight areas. If there's been a surgery, doing a scar massage or a cross-friction massage to get the scar to mobilize and move better. Strength training, of course, proximal stability, so we're focusing on gluteus medius, on transverse abdominis, pelvic floor, which oftentimes we strengthen with the transverse abdominis, kind of all as one unit. And then gait and balance training, working on weight bearing and weight shifting and postural control, then getting balanced in various positions, and then eventually functional mobility and endurance training, getting them back to their prior level of function, or even better, especially with people who've had a hip replacement. Sometimes they get to a better level of function. Okay, so our stretching exercises, the main areas that we typically need to stretch are the psoas. Here is a psoas stretch that's pretty intense. And I'll show you one where you can actually just lay kind of sideways on the table and let that leg hang off the table. That could also stretch the psoas for another patient that maybe can't tolerate that position. Hip flexor stretch, of course, this is also stretching the hip flexor. Hamstring stretch, you're familiar with. Piriformis stretch right here, you're familiar with. Adductor stretch, you know all these, but just reminding you of which areas to stretch in a hip patient. With strengthening, I've already mentioned the gluteus medius. Here's a new exercise I found for the gluteus medius. So you're abducting the leg and you're also pushing into extension in order to hold the cloth on the wall and slide it up and down. So it's still at that kind of 45-degree angle. As you abduct up, you're also pushing back. So it's really tightening the gluteus medius. I really like that. Remember, with transverse abdominis, regular planks and side planks are great for that and for, all of our core stability muscles. And then with multifidus, something that we haven't talked a lot about in class. So the multifidus is at the very bottom part of your back near the sacrum. And one of the ways that we initiate strengthening of the multifidus is what we call a knee liftoff. So they tuck their toe on the table and the knee is relaxed onto the table, and then they straighten the knee out by trying to activate just the lower back. So you tap on that area. We'll work on this in class. You tap on that area on the lower back and you say tighten here and pull your knee up towards the ceiling. And then, once they're able to do that, they'll hold it for a few seconds and go back down. Usually you'll hold them for 3 to 5 seconds and do 5 or 10 of those on each side, on each leg. And then eventually you can do where they straighten the knee out and then you point the toe. And so there's nothing contact in the ground. It's all being held up by the multifidus. And then you put the toe back down and then the knee back down and then switch legs. Straighten the knee out, point the toe, back down, back down. And that's a progression of that. And you could probably eventually go to just the flutters, leg flutters. But the only problem with really going with mobilizing exercises is the multifidus is just a stabilizer. It's not a mobilizer. So once you start to really do back extension or lower extremity flutters off the ground, things like that, you end up activating most other muscles and not necessarily the stabilizers nearly as much. So I would recommend this way up here and just progressing that. And it would take somebody really strong to really be able to activate the multifidus while they are activating all these other muscles to bring in the extensors. But we'll go through that progression in class. All right, so the loose pack position for the hip, 30 degrees of flexion, about 30 degrees of abduction, and slight external rotation. So this lady looks real happy about having the patient's leg hanging out in the loose pack position on her shoulder, but 30 degrees of flexion, 30 of abduction, and slight external rotation. The closed pack, so where the joint is the closest together, is extension and internal rotation, which we don't necessarily use. We typically start out in the loose pack and then we'll go kind of towards whichever movement we're trying to increase. So if it's flexion, we would go in more of a flex position. If it's abduction, we go into more abduction from there as we progress the joint mobilization. We typically do not use an anterior joint mobilization. I'm just randomly mentioning this here, but because the anterior capsule is typically not tight. Just like with the shoulder, typically the anterior capsule is loose, and if they're going to dislocate, they'll dislocate anteriorly, and it's the posterior capsule that's tight. Same thing with the hip. The anterior capsule is typically not tight. It's usually a little bit more loose, and it's the posterior and sometimes the inferior that really need to be stretched. So we rarely do an anterior joint mob. But if there is anterior instability, it could be related to a loose capsule, which means we also need to stretch the posterior and do hip stabilizing exercises, or to a muscle imbalance. So if it's a muscle imbalance, make sure you're stretching whatever's tight, strengthening whatever is weak. Okay, axial distraction, long bone distraction. You're grabbing the patient's calf and pulling downward in a distraction force. So typically we do have it kind of towards the loose pack position, so about 30 degrees of flexion, 30 degrees of abduction. Could have it in a little bit of external rotation, and you're just doing a straight axial distraction, so just pulling inferiorly. What we use this for, this can be pain relief. It can help the patient relax, to do other techniques, and it can also increase flexion and abduction. Both of those would require somewhat of an inferior glide as they go towards the last degree superiorly. And so it can help with stretching the inferior capsule to help with flexion and abduction. Okay, so here is a true inferior glide, and typically we have the patient flex the hip and knee to 90 degrees, and you can stabilize the pelvis by putting a gait belt around the patient and the table. And then, apply an inferior glide to the femur. So typically we do it to the proximal femur, right up next to the joint. And what this therapist is doing is using a mobilization belt to attach very close to the joint, same area that this man has his hands, and doing the inferior glide that way. So especially with a patient with a really heavy leg, you may end up having to do more, with a belt or something just to get your mechanics right. But you could also try, with just your hands based on what you're comfortable doing and what meets the patient's needs. And this inferior glide is used to increase hip flexion range of motion. With a posterior glide, so we typically put the patient in the loose packed position, and then we stabilize the posterior femur near the knee. So down here we stabilize, that's in both pictures where the mobilizing belt is. And then you apply a posterior force to the proximal femur. So you push down on the proximal femur. I just showed you this example because sometimes when they're hanging off the end of the bed like that and pulling the leg up, it gets really a lot of weight on the therapist. It can get to be kind of a hard position. So you could just have them laying sideways on the bed like that and perform it that way. And then this will help increase internal rotation and flexion. So the last three we've done: distraction, inferior glide, and a posterior glide are all three increasing flexion. With the distraction, that also increases abduction. With the posterior glide, it also increases internal rotation. A medial glide is used to increase abduction. So you abduct the patient's leg in about 45 degrees. You support the underneath surface of the leg so that they're able to relax, and then you apply a slight medial force. Now, what I do when I apply this force is I don't apply it straight down towards the other pelvis, towards the pelvis and other hip, because then that's just basically a compression. And remember, compression is not best because it can break down the cartilage. I apply it at an angle. See how his hand is at an angle? So it's actually getting applied towards the opposite knee, towards in line with the groin, really. So you're applying a force down that way. So it's still kind of an inferior and medial glide versus just straight inferior, just pushing the bones together. And this will increase your abduction range of motion. With a lateral glide, we are pulling the hip straight laterally. So it kind of opens up the joint space, and it can decrease the impingement if they are having, it's kind of a distraction force to open it up to decrease impingement. So with this hand, he's just stabilizing. This arrow looks like he's pushing in, but he's just kind of stabilizing as he pulls out with the mobilization belt and with his hand. Typically, the patient is in 90 degrees of hip flexion, and then you pull laterally. And you can hold that while you're having the patient flex and extend their leg. And I guess I didn't put any of these pictures in the slide, but there's a lot of pictures on the internet of people doing this themselves, having a mobilization belt that's tied to a piece of equipment or something, and then around that part of the leg, and it's pulling it laterally as they're doing lunges or as they're doing knee lifts or something like that. There's also some with them doing an inferior glide. So if they are having impingement while they're doing the strength training, they can do a lateral glide and maintain that glide with the mobilization belt as they're moving in other positions other than supine, standing and kneeling. Okay, so another treatment technique, and we'll work on this some in the lab, is a IT band myofascial. Oh, we'll do all the other joint mobs in lab as well. Myofascial release. So the IT band is primarily myofascia, and it often gets tight and puts pressure typically on the knee. It could put some on the hip, but typically you feel the pressure on the knee, maybe some lateral knee pain. It could also cause the patella to track laterally. And so to do a myofascial release, what I do is find the restricted areas. So I typically go along the whole line of the IT band, and if it's really tight, you can see it in the patient. You can see exactly where it starts and ends, and do kind of a distraction force, so a gliding force. So if this is the edge of the IT band, I push on it and I mobilize it away from the tissue, trying to pull it away from and stretch it to release the tissue. So I go basically, if this is the IT band, I would go along this border and that border. You can go on, the body of it itself, that's fine, but I typically go on the top border and the bottom border, take my hand and mobilize it all throughout the top border and then mobilize it all throughout the bottom border. Sometimes I will do like a kind of like rolfing we do on the hamstrings, take like a fist and rub it up and down the IT band. That can help. Of course, they can do a self-mobilization with rolling it up and down on a foam roller. That's one that patients seem to really get a lot of relief from. It's painful and they may bruise, but they typically get relief. And then cupping can also do this myofascial release. That's what cupping is made for, is a myofascial release. So if that's something that you get trained in, I would highly recommend. I've had patients get great results with, it was actually the PTA that I worked with, because I didn't do cupping, but she did, and she's had several with great results with cupping of the IT band. Really releases that. In our final slide, we need to review these in the clinic, these things that we've learned in previous sessions for other body parts, but they work here too. A psoas release, piriformis release, rolfing of the hamstrings. Of course, she's not necessarily doing rolfing, but I couldn't find a good picture of one that was. And then the SI joint muscle energy technique. So we'll go over those again, review those in lab to make sure we still have good technique with those. And we will go over our case studies in lab as well. So here is our first case study. If you want to pause it and look over it before lab, of course, you're always welcome to. And our second, right here. So we had in the first one a female who fractured her hip, and now a pregnant female with SI joint dysfunction. So we'll go over those in lab. That will be the end of our session today. I hope that you learned a lot.